Haven't subscribed, please do subscribe. This is a concise, well-crafted summary and it highlights only the important keywords. Aortic dissection. So aortic dissection is a circumferential or the transverse tear in the intima, circumferential or transverse tear in the intima, and the blood enters the intima medial space. Blood enters the intima medial space. So the separation of the inner and middle layer, of the inner and the middle layer. The most common site is the right lateral wall of the ascending aorta. The prevalence, if you see, it is more common in case of male, and it is typically seen in the 6th to the 7th decade. The risk factors is a systemic hypertension and can include the cystic medial spaces, medial necrosis. Then there is also the 3rd trimester of pregnancy. Now, how is the classification? The classification is there is something known as a type 1. The type 1 it involves ascending and the descending. Next comes the type 2. The type 2 is limited to the ascending aorta. Then comes the type 3. The type 3 it involves the intimal tear. So intimal tear in the descending. Intimal tear in the descending aorta with the distal propagation. With the distal propagation. Next comes the Stanford. The Stanford classification. The Stanford classification it includes A and B, that is 1 and 2 of the D bucket, as well as Stanford B. Stanford B is nothing but the D bucket. So Stanford A is 1, 2 and Stanford B is 3. Next, moving on, what are the clinical features? Clinical features, they can be a sudden onset of the severe chest pain. So sudden onset of severe chest pain to the interscapular region, and there is also the pain which migrates to the dissection propagation. Next is there is presence of syncope, that is dyspnea, as well as there is weakness and the hypotension and shock. Next, what we look at is the investigations. There will be widening. There will be widening of superior mediastinum on the left sided. Next is there is a CXR, that is a chest X-ray, and the choice of imaging depends on the patient stability. The stable is nothing but the CT angiography. It is very stable. Then unstable, if you see, it will be the transesophageal echocardiography. Then comes the management. Management is by the emergency Dacron graft repair. Dacron graft repair. To learn and grow daily like this, please do subscribe.